I have no clue what they're talking about, so don't worry about it, please. Everybody, thanks for joining me. I'm looking forward to working together to help all the folks that we see for the next couple of months. And I'm joined by Jen Stanley, who's going to introduce herself. Then we'll get going. You'll also see, in addition to me and Jen, Amanda Brown, who's a wonderful colleague with both of ours. And Jen and Amanda will fill in for me as something comes up, and we'll conduct the same trainings. I'm responsible for the content, so blame me. And this is basically something that I've been doing, safety training and suicide prevention and seeking safety for a number of decades, all over the state, working with all sorts of different folks. And I know that safety planning is increasingly important in all of our work. And it's not just for suicide, but any people at risk for any kind of problem. And we'll talk about that. So the way that we're going to start, and then I'll let Jen introduce herself, is we're going to spend 4 weeks doing safety planning. Today, we're going to do the prologue to that with risk assessment. And then the next 3 sessions, we're going to hone in on safety planning in a lot of detail, including access to lethal means counseling. And then we'll switch to going to seeking safety, which is a treatment designed, one of the first evidence-based treatments for co-occurring substance use disorders and trauma, as well as other severe mental illness. And we'll wrap it up by showing that seeking safety is actually about 80 to 90% safety planning and has a lot of modules that are really, really helpful in designing safety planning. So Jen, if you'd like to say a few words about yourself.
Yeah, I'm excited that I get to be one of the collaborators, and I use they, them pronouns. I live here in Albuquerque. I used to work at PES, so I maybe have worked with some of you before in that capacity as a crisis counselor there, and then more recently on a county suicide grant at First Nations through the primary care, their homeless outreach and primary care clinics. So it was using SBIRT with the screening, brief, intervention, referral to treatment, and then using a lot of the modules we'll be going over. So by no means can I say I have decades of experience, but I'm pretty passionate and care about the work, as most of us do. So I'm excited to just be a part of the discussion and reflecting ways that we can bring these skills in more than we are, or to share how the strategies that we're using are working.
And Jen alluded to the SBIRT grant, and I was the consulting psychiatrist and the PI for UNM for 2 5-year iterations of the SBIRT grant, where we introduced seeking safety to the state. And Jen was part of that experience, working with a great colleague of ours, Curry. So moving on, today, the objectives are to describe key components for risk assessment. It formulates an action plan for crisis intervention and disposition planning. And safety planning should always, always be part of risk assessment. And we'll talk about why. We're going to talk about the Columbia Suicide Severity Rating Scale, because that is what UNM adopts. There's a few evidence-based protocols for suicide prevention screening. And the Columbia screen has been normed and evidence-based in all ages, including children, as well as adolescents, youth, and adults of all ages. And then we're going to talk about how to utilize that, and we'll give a little bit of an example for a case that we'll discuss. Now, before we go into this, for the whole training series, and people who've been with me before know, whenever I create a PowerPoint, it's really as a reference for you. And all of the people who register will be getting a PDF of all the slides with all the references from Alex and Anthony, who are great supports. You met Alex earlier today. So don't furiously worry about copying notes and taking notes. And I'd like you to Ask any questions you have in the chat. I'll monitor it as we talk. This is a collaboration, and Jen and I will be conversing with each other. We want to model what safety planning is, which is a collaborative conversation. It's not an authoritarian, directive, prescribed kind of intervention. It's very much of a patient-centered, collaborative conversation. So we hope to model that today and in everything that we do. Nothing to disclose. And what I like to start with is that, and I think I'm going to change the view so you can see it differently. Suicides are preventable. And the main way that they're preventable is restricting access to lethal means, early identification and treatment, dealing with how media reports, because with problematic media reporting, we get a lot more suicide contagion and suicide clusters. So it's really important to deal with that. And then as far as this being important, especially with lethal means access, generally, surprisingly to some of you, a suicidal crisis is very, very transient and very treatable. 90% or more of people who attempt suicide do not go on to die by suicide. Now, again, for a lot of us who work in the mental health center, we see people who have severe mental illness, so they're outliers for the general population. But the vast majority of people, even who make a life-threatening suicide attempt and survive it, do not go on for further attempts and do not kill themselves. The other thing that's important is that a lot of people make the determination to make an attempt within minutes of a precipitating event, not day after day, week after week, planning it. So if in the moment we restrict access to lethal means, give them coping skills of when they feel this sudden urge to end their life or to not face the future, how to handle it, which is what safety planning does, how to call in people who can be of help, how to rely on their own resources, which is where we start with, how to look at reasons for living as opposed to reasons for dying. We can prevent suicide. What's important in today's discussion is that we're terrible at predicting suicide. We can only predict for the next couple of hours or days based on what we see, but we can prevent. Not everyone, but most. And another way that I like to review things is that, contrary to myth, most people in a very extensive survey of a lot of different people in our country just a few years ago, 95%, 94% believe that suicide can be prevented, and this is important, and they would take action to help someone close to them. So this idea that anyone who wants to die will kill themselves, that suicide is nothing that people attend to or want to be involved with, is not true. There are helpers everywhere. There are supports everywhere. And a big part of safety planning is looking at the supports that people have naturally, as opposed to relying on all of us. It's a leading cause of death in the United States. And I'm not going to go into the weeds in the statistics, but in New Mexico, and these are older figures, we get them 3 or 4 years later after the fact, but who are people who are at risk in New Mexico? Whites are at high risk, American Indians are at high risk, and the suicide rate, so the people who die from a suicide attempt, is much greater in men than women. Now, unfortunately, that trend is changing because women are becoming more involved in a suicide attempt using firearms or jumping from a height or suffocation and strangulation, which are the most lethal. If you mainly attempt by pills, as we'll go into, your chances of survival are very great. Very few people die from overdose. But many who use, most who use firearms die from the attempt. So the means of attempt is really important. And at one point in 2018, we had the highest suicide rate in the country. And some of that is because of structural poverty and lack of access to care, as well as all sorts of other factors. So going into statistics from 2018, which is basically 2017 data, on the average in New Mexico, one person died every 19 hours in the state. And it's more than that at this point in time. For a long time, it's been the second leading cause of death for ages 15 to 44. And it's the 14th leading cause of death for 65 plus. So one thing that I wanted to comment on is that for most stigmatized communities, under-resourced, stigmatized, and otherwise neglected or criticized or ostracized by larger society, the suicide rate is higher. But it's not inherent in people if they're refugees or immigrants or LGBTQ. It's more the fact of if they have a supportive, affirmative environment, their suicide risk is identical to everyone else. So one of the things that we can really do is destigmatize populations at risk and find ways to support their identity and support who they are, to again support reasons for living. So there are significant cultural considerations that we have to look at. And we also have to look at that, why is New Mexico rate high? Because of these disenfranchised folks and cultures, and the fact that rural areas and impoverished areas have a lack of access to services, including preventive services. And they have a lack of the social structure that supports healthy living and reasons for living. We also want to talk about COVID considerations, which are significant. And initially, it was reported that COVID had actually no effect on mental illness in general, including in youth and in children. That's proven to be totally false. All of us in the field knew that it would be. The risk of suicide has actually quadrupled because of COVID, primarily because of social isolation. And in fact, in New Mexico, unfortunately, we've had a number of suicide clusters in our state during heavy social isolation and the lack of face-to-face schooling. And the issue with that was so prominent that a lot of the survivors, like in high schools and middle schools, angrily petitioned the state to go back to face-to-face learning, not so much for the academics, but for the social contact. And if you think about how important peers are and peer relationships are to children and to youth, and that we're depriving them of that, including all the extracurricular activities, which are so important, you can understand that. So as the social isolation eases because of COVID, so will the mental health of our population improve. Now, if we're looking at comorbidity, more than 90% of people who die by suicide have a mental health disorder or a substance use disorder or both, which is why you're all here. More than 50% of suicides are associated with a major depressive disorder. Approximately 25% of suicides are associated with a substance abuse disorder. And these are always underreported. Suicide itself is underreported and relatively underdocumented. And so are all these comorbidities. The consequence of suicide is enormous for the families. And one of the things that I discovered doing suicide prevention is that when I did this at schools or in communities, people would come to me not to talk about suicide prevention, but about the impact of suicides in their community, in their families, in their lives. And one of the things that, if you are interested, we can talk about at some point in the future, or I can guide you to references, or you can contact me by my email, is about how to diagnose those people who suffer traumatic, prolonged, complicated grief. There's a specific evidence-based treatment that I'm a trainer in that I can talk to you about. And what's really important for our colleagues that aren't in behavioral health, they see people at risk for suicide far more than behavioral health folks do. 50% of people who die by suicide had contact with primary care providers in the month prior to their suicide. And in most cases, that risk was not documented. 80% of people who die by suicide had contact with their primary care provider in the year prior to their death. 20% of people who died by suicide saw behavioral health providers. So you see huge disparity between behavioral health providers and healthcare in general. And 10% of people who die by suicide visited the emergency department within 2 months before they died. And in most cases, their suicide risk was not discussed, was not looked at, no safety planning was done. So there's many windows of opportunity, and like we'll talk about, there are forms of safety planning created for emergency departments that take less than 10 minutes, and they have promising results in reducing both suicide attempts and suicides. Myths that you need to diffuse and counter in the community are, if someone is really suicidal, they're probably going to kill themselves at some point, no matter what you do. So why bother? Asking a depressed person about suicide may put the idea in their heads. This is a really problematic myth if you're trying to do screening in a community, especially in the schools. If parents have the feeling that if you ask about suicide, you're somehow hypnotically inducing suicide, of course, they're going to oppose screening. All these myths are myths because the data is the opposite. If you ask somebody about suicide, they're relieved that they can talk to somebody about it because like everything else in life, they're ambivalent. So it's really important to feel free to ask. And this idea that if somebody's suicidal, they're going to kill themselves no matter what you do, remember that most people, if they do feel suicidal, it's only for a few minutes or a few hours. And if they have skills and supports, they don't go on to kill themselves. And most people who survive a potentially lethal attempt never do it again. So it is not true that people are relentlessly, chronically suicidal. Jan Fawcett, who used to be an esteemed colleague of ours at UNM, found that it was made only in people who were middle-aged or older, who had persistent major depressive disorder that was non-responsive to any kind of treatment-resistant depression. That is the subgroup that felt almost like people with terminal cancer. They had tried everything, nothing would relieve their suffering or pain, and that's why they turned to suicide. But that's a very small group of people. Someone making suicidal threats won't really do it. They're looking for attention. And my response to that is, we're all looking for attention. That's how we connect to people, right? We want to be attended to. We want to attend to other people. If I can give you one thing to work with youth and teenagers, don't talk about seeking attention. We're all doing it today in our gathering right now. And also, if you can, eliminate from your wording suicide gestures. It's a message, it's a conversation. Anybody who talks about it says, on some level, I'm suffering, I'm having difficulty, help. If you stop someone from killing themselves one way, they'll probably find another. Again, not true. So please understand that these myths will come up in the people that you see and know the data to diffuse it. I don't think I have to belabor what a suicide attempt is. I think we all know the definition, and we'll go into that when we talk about risk assessment. So managing persons at risk for suicide is complex, and it requires collaborative partnership between the affected person, their support network, and a multidisciplinary healthcare team. Now, this is really critical, collaborative, strength-based. This is the way to prevent suicide. Not directive, not prescriptive, not one up, one down, not expert to patient. We're working with people together. We're being guided by them. They're the experts on who they are. They teach us. They tell us what works for them and what doesn't. We support what works. We give them mentoring and coaching and support to help them be at the place that they want to be. And as we'll talk about today and for the next couple of weeks, we start with what they're concerned about and work with embellishing the coping skills that they already have in place and opening their eyes to other possibilities that they can cope totally on their own. Then how to draw from their supports for help, for connection, for counsel, for guidance. And only then, after they've worked through all those resources, which are plentiful, do they turn to professionals like us. And typically, like you know, in risk assessment, we do a binary, do they need the hospital or not? And if not, we make a referral. We don't go through anything about what their strengths and competencies and skills and interests are, who their supports are, how to help them cope, and to monitor what works and what doesn't work for them, and to have them feel that they have much at their command and that we're there as a scaffold, not as a foundation. We're there to temporarily support them to achieve a place of better well-being. So what is screening and risk assessment? And we want to make a distinction between the two. Oftentimes they're conflated. So the current standard for responding to suicide risk is screening, which is what the Columbia screen is. It's a screening device. It's not a risk assessment device unless it's been modified. Universal screening means that we ask everyone, no matter what they come for. So the SBIRT program that Jen and I alluded to briefly, anybody who walked into a medical clinic, we screened for risk factors for substance abuse, for depression, and for trauma. They could have come in with a sprained ankle, but we asked about it. In the same way that every time you see a healthcare provider, you're asked general questions about a variety of symptoms. And that's because a lot of people will only talk about this if you ask the question. Risk assessments are stratifications of risk that classify individuals as high or low risk for future suicidal behaviors in order to determine what kind of aftercare we want. Now, what's really important, again, is getting away from this hospitalize or not, refer, because most people don't follow up on referrals. Hospitalizations are often brief, and the greatest risk for suicide, unfortunately, is upon discharge from the emergency room or inpatient psychiatry. The greatest risk for killing oneself is within 1 to 2 months of a discharge from an emergency department or a brief inpatient stay. So hospitalization doesn't solve things, and referring people into the community without giving them coping skills, without outlining the supports they have, without helping those supports help support them better, does not work. And lethal means access counseling is absolutely critical. So what's involved in screening and risk assessment? Assessing for suicidal ideation, intent, and planning, identifying risk factors and warning signs. And we're going to talk about the difference between risk factors and warning signs and protective factors. It's really important to know the distinction. Warning signs are what's important to that person. So if one of us feels a lot of despair because people criticize us, that might not be the typical kind of risk factor, like a family history of severe mental illness, but that is a message to that person, or somebody who can't sleep because they're constantly ruminating about things that people said that disturb them, or relationships that are seeming to fail. We want to identify again what says to that person, I'm getting out of control. I'm drinking too much at a party. I'm taking drugs that I normally don't use because I have too much pain inside. So that's really important. Risk factors we'll go into the weeds of, but a typical risk assessment focuses on risk factors, not warning signs. Safety planning starts with warning signs. Big, important distinction. And protective factors are unique to each person, just as the risk factors are. We can talk about risk factors for general populations, but it's important. And risk factors and protective factors are not the opposite of each other. There's some things that are very distinctive about protective factors that are not like the absence of risk. It's really important to look at reasons for living as opposed to reasons for dying. Identifying lethal means and lethal means access is really important. And this is something that I add as a child and adolescent psychiatrist, but it's really important for all ages. Assessing the capacity of the home and the home environment to provide an emotionally and physically safe place that's conducive for safety, security, and enhancing reasons for living. So one of the things, I did a study about 20 years ago in some hospitals in metropolitan New York about what went into the decision-making for child psychiatrists about psychiatric hospitalization. And what we found is, not surprisingly, that people could be even at severe risk, but if they had a wonderful, supportive parents, family, siblings, school, where aftercare was excellent, supervision was excellent, and lots of support for counseling, especially strength-based counseling, they did extremely well and did not need to be hospitalized. But youth who individually seemed to be at mild to moderate risk, but had chaotic, destructive, traumatizing, discouraging, stigmatizing environments. If you went by the risk assessment alone, you'd say they don't need the hospital at all, outpatient, not even intensive outpatient or any kind of significant aftercare. They were at great risk. So it's always important to look at guardians is the term, but even the elderly. You know, there's a lot of elder abuse that goes around, especially for people who have multiple medical problems and cognitive issues, et cetera. That can also be problematic. So always, always focus on the context that you're discharging someone to. Look at safety in their environment and not just lethal means. And as an example, hanging, unfortunately, is very common in youth who try to kill themselves and often successfully do so. And so guardianship and supervision and monitoring the environment, we can't take every single ligature away from someone. It's not possible to find every belt, every drape cord, et cetera. So we rely a lot on guardianship and supervision and caring. If we have parents and families who don't want to support transportation or funding, or say that therapy is useless and doesn't work, or won't in any way support, or will actually further traumatize and stress the individual or demean the individual, or say that they're just crying wolf when they're talking about suicide, you can see how problematic that is. So I can't emphasize this enough. Factor guardianship and family context into your assessment. It's not typically listed as part of the assessment tools, but it's essential. So screening suicidal thoughts alone are of limited predictive value. And I don't have to go into the weeds of this, you all know that. We have an American College of Suicidology, suicidologists, people who specialize in this. And we're very bad at predicting suicide, but we're getting better and better at preventing suicide. That's why we need to talk about that. Many are unwilling or unable to reveal active suicidality. A disproportionately large percentage of patients in healthcare settings are either unwilling or unable to reveal active suicidal thinking and motivation to die when responding to direct questions. one of the limits of our risk assessment tools. And there are many reasons people refuse to reveal. Why? Stigma, fear of hospitalization, fear of losing their legal rights, bias in retrospective recall, they can't remember, with the end result being that about 70%, 75% of those who eventually die by suicide deny suicidal thoughts when screened. And so it's really important to, in your assessment, look at other factors, which is what we'll talk about, how to look at those. Screening tools do not capture moment-to-moment variability of suicidality. And all of those of you who work with youth know that a majority of youth are suicidal because of an interpersonal crisis, typically with a peer. And a lot of them might meet criteria for major depressive disorder with atypical features and reactive, abandonment, rejection, sensitive mood. So they seem to be sailing along okay. And then someone who they rely on is not available to them, is cheating on them with a friend of theirs, or is dissing them behind their back, in some way demeaning, criticizing, abandoning, not supporting them. And in that moment, they feel helpless, hopeless, and just want to end things. So it's really important that no suicide risk assessment can really capture that. Suicidal thoughts ebb and flow, with episodes for adolescents fluctuating much more rapidly than for adults. And a study of youth, 13 to 34, showed that for 25%, the time between the decision and the action was less than 5 minutes. Less than 5 minutes between thinking about suicide and wanting to do something about it. Only 14% of suicide attempts occurred more than a day after the decision had been made. Again, it's typically transient and it's precipitating events. That's why identifying those warning signs for each person is so important. What promotes and activates suicide? Now you'll notice I did not use the common word trigger. There's a really important reason for that. Most people who kill themselves in a suicide attempt use guns. We don't want to constantly use the word trigger, trigger, trigger to trigger them thinking about triggers and guns. Just like we don't talk about committing suicide as if suicide is a crime. We talk about people who kill themselves. So a suicide risk assessment needs to evaluate self-management. Self-management is a key part of safety planning. Without doing safety planning, we can't assess self-management. Multiple attempters evidence poor or limited capacity for self-management. And the way that we define crisis, right, is that our repertoire of coping skills are insufficient to meet the demands of the moment. So how can we fully assess somebody's risk without looking at their ability to cope? But we do that all the time. So we don't want to focus solely on suicidal ideas, plans, and attempts. We have to focus on reasons for living and ways for living better. So to go into the Columbia Suicide Severity Rating Scale, which you've all hopefully been trained in, it's part of a suicide screen, not a risk assessment, and it's the suicide inquiry. And what we're looking at is thoughts, plans, behaviors, and intent. And there's 6 questions that lead us gradually into that. So the first place that we start is a wish to be dead or not alive anymore. And this is very important to talk to with children. A lot of children don't have the concept of the permanence of death, right? So what do we say instead? Have you thought about what it would be like to have to face tomorrow? Do you have the wish like that you never would wake up? Or that you could stay in bed all day? Or that you could go to sleep and the sleep would last forever? And then for some people, do you wish you weren't alive anymore? Or have you thought about what it would be like to be dead? And what kinds of things come up when you think about what it would be like to be dead? It is not adequate to say, have you ever wanted to die? And that's the only question that we ask. We have to find a way of communicating what we're really saying is life so miserable and painful to you that it's unbearable to face? Again, this idea of somebody with end-stage cancer who has bone metastases. Bone metastases are the most painful, and they're on morphine drips and it barely touches it, and they just don't want to live that life anymore. Do you have a life that sometimes feels not worth living? That's what you're looking for. And then if they say something along that spectrum, then you ask the next question, which is non-specific thoughts, without method, without plans, without behaviors, without intent. Have you thought about doing something to make yourself not alive anymore? Have you had any thoughts about killing yourself? Have you any thoughts about how not to wake up, how not to face the day, how not to deal with everything that you're dealing with? And then you move to ideation without intent to act. Have you thought about how you would do that or how you would make yourself alive anymore? So all of you, I'm sure, are steeped in the Prochaska di Clementi stages of change. So what we're talking about is moving from pre-contemplation to contemplation to preparation to action. That's what we're really doing. So our first questions are pre-contemplation, and then we look at contemplation. So it's like, well, when you begin to think about it, what might you do? What kinds of things do you think about? Do you think about pills? Is it very vague? Do you think about, I wonder where my dad keeps the hunting rifle and the ammunition? I haven't kept track of that. What's going on in your mind? So you're not planning to do anything, but you're sort of flirting with the idea, contemplating. And then we move from that to some intent that's behind that kind of contemplation. When you thought about making yourself not alive or killing yourself, did you think that this was something you might actually do? You might actually be motivated to try, right? This is different from opposed to having the thoughts, but knowing you wouldn't do anything about it. And when we do studies, for instance, of adolescents, 3/4+ of adolescents have suicidal ideas 3 or 4 times during the course of the year, at least. And this is by self-report. Again, it's always underreported. So a lot of people think about it, but they have no specific plan and they know they won't do it. It's just a thought that they have about, God, life is really tough. I wonder what it would be like to end my life. Okay. And then we move from some intent to a specific plan. Have you decided when you would do it, how you would do it? Have you planned out, worked out the details of it? So that might be knowing where the guns are, knowing where the ammunition is, knowing when people are not home to see you, knowing where the drugs are, knowing what drugs you might take. What was your plan? When you made this plan, was any part of you thinking about actually doing it? This is a really useful question. Any part of you. That's again goes to the ambivalence, right? A lot of people will talk about things as binary, when we do these risk assessments. Have you thought about, and if you say, have you ever thought about it, they'll say, not really. Well, did some part of you sort of in the corners and the crevices of your mind start to think about it? And then people will say, yes, okay. So these are the 6 questions that we're looking at. Wishing, thinking in a vague kind of non-specific way, more concrete thoughts, thinking about potential methods, again, contemplation, and then motivation and intent, and then started to work out the plans, preparation, right? Have you ever done anything, started to do anything, or prepared to do anything to end your life? Anybody have any questions on that, about the distinctions with that you want to type into the chat or unmute yourself? Does that feel relatively clear? Okay. And then if we're looking at risky self-injurious behavior, this is something that I always insert. It's not part of the Columbia screen, but it's very important. Some risky behaviors, with no conscious wish to die whatsoever, it may result in death. Some risky behaviors with a conscious wish to die, what may not result in death. And it's important to determine the relative risk of both instances. I always use this example because it's very graphic. So years ago, there was a family with a 6-year-old, very chaotic, very traumatizing kind of family, in and out of rehab, in and out of troubles with the law, and there was a lot of domestic violence, et cetera, et cetera. So there was this 6-year-old boy, and he was living near the Big I in Albuquerque, totally unsupervised, and would go out into the street to play and sometimes wander off and get really close to the Big I, to the intersection. Now, did he want to die? Did he want to escape his family? No, he was just being out and about, totally unsupervised. There's the guardianship and the supervision again. Was he at high risk for dying? Absolutely. Was he suicidal in our traditional sense? Not at all. Then you take a 16-year-old girl who had very mild subclinical features of depression, most in relationship to, again, peer conflict and concerns about her first boyfriend and whether or not he was faithful to her. She thought about suicide off and on in the very first kind of way, very vague, very nonspecific, no intent, no plan, no behavior, no trials, and all that. Did she endorse suicidal ideas? Yes. Was she at risk for ending her life? Extraordinarily low. But in our risk assessment, the young little boy would not register at all. He wouldn't even be screened. And the girl would be screened and triaged. And in some schools, if you say at all that you have thought about suicide, they immediately shuffle you off to the emergency room to be assessed for hospitalization. So we have to be really mindful about our risk assessment and how we document it and what it means. Does that idea about that there are people who put themselves at risk who are not suicidal in any way, or their setting or their family or their supports or lack of supports put themselves at risk? And then there's people who have risky behaviors with a conscious wish to die that may not result in death. Another example of that is, I knew a lot of kids, for instance, who knew that Tylenol was really bad. Some thought it was for your kidneys, it's actually for your liver, but they knew that it was really bad to take an overdose. And to them, they took an overdose, meaning that if they normally were supposed to take 2 Tylenol a day, 2 extra strength, then they thought they would take 8 and they would die from it. Now, it wouldn't kill them, okay? So a lot of people dismissed it as saying like, well, if you really wanted to die, why didn't you take the whole bottle? But in their belief system, they thought that those 8 pills were going to kill them. So they actually were at high risk, because if they had taken a drug that actually could kill them, they would have died. So we don't also look at their behavior, we look at their belief about that behavior, if that makes sense, okay? And I've known a lot of people who said like, well, if they really wanted to die, why didn't they have the whole bottle? But they thought that they were going to die. The flip side of it can also happen. I've known a number of kids and young adults who've ended up in the emergency room and sometimes had to go to the ICU because they wanted to sleep. And they knew that mom or dad took 2 sleeping pills instead of the one that they had used. And they thought, well, if 2 sometimes doesn't work for them, I might as well take 4. And then they had respiratory distress. Did they want to die at all? No, they just wanted a sleeping pill that worked. So we have to be mindful of all the complexities of this. Now, there is a risk assessment version of the Columbia Suicide Screen. And that's important to know. Are you using the screen or the risk assessment version? That goes into suicidal and self-injurious behavior, suicidal ideation in the past week, activating events, notice that as opposed to triggers, treatment history, other risk factors, clinical status, protective factors, the suicide inquiry, which is the screen, and actual and potential lethality. So the risk factors, and this is from the DBT team. What do people, both adults and youth, feel when they describe what is most stirring of them in reasons for dying? Misery in their mind, psychological pain, stress. And this is not stress in the way that we think of it, it's being pressured, overwhelmed. Agitation is not physical agitation, psychomotor agitation, it's urgency. It's feeling that you need to take action. Hopeless, we all know about hopeless, helpless, worthless thoughts. But this is that no matter how much I try, no matter what I do, so it's both helpless as well as hopeless, nothing will ever get better. And sometimes that's realistic. Again, I've worked a lot with kids with cancer, that's why I keep referring to it. But sometimes the prognosis is incredibly bleak, nothing will work, nothing will relieve your pain. And that's why we talk about New Mexico just recently passed a law where people with terminal cancer, with excruciating pain and very low standards of living and quality of life can get medical euthanasia. Self-hate, disliking yourself, having no self-esteem, which is, it's much harder than no self-esteem, it's really self-hate. So risk factors, we all know about populations at risk, we know about comorbidities, stressors, family history, I won't belabor that. Protective factors are both internal and external. Internal is, I can identify reasons for living. I have hope for the future. I have an attachment to living, to belonging to others, to connecting to others. I have religious beliefs or spirituality which supports my reasons for living. I have some kind of confidence that I can solve problems or cope with stress. I've done it in the past, I can do it in the future. I have reasonably good frustration tolerance. And a very important protective factor is actually negative. I'm really afraid of suicide. I'm afraid of dying. What if I take a lot of pills and I don't die, but I end up a paraplegic, or I end up mindless, or I end up on a heart and lung machine for the rest of my life? And it's really important too, to treasure people who talk about suicide a lot. It's much better that people over-report feeling suicidal than under-report. And oftentimes we dismiss people that way. We get annoyed by people who are constantly saying, I wish I would die, I wish I would die. It's a communication. It's a conversation that they want to have with us. We need to be empathic with that. There's a whole inventory that was developed by David Jobs, who was part of the initial Linehan team and went off to elaborate on a suicidality specific form of treatment, the collaborative assessment and management of suicidality. I'm a trainer in that, and I've offered a lot of trainings throughout the community for that. It's a strength-based collaborative approach, and there's a whole inventory of reasons for living that you can suggest for adolescents to look at what kinds of things that they can identify that make them want to go on. On some level, they accept themselves for who they are. They have a lot to look forward to. They have friends who stand by them when they have a problem. They feel loved by some of their friends, not all of them, but some of them. They feel somewhat close to their family, et cetera, et cetera. So this is just to generate reasons for living. The way I always like to end these kinds of talks, by the way, is recovery is not the fact of being without substances and being without risk. It's not the absence of something negative. It's the presence of something that's wonderful, that's future-oriented, meaningful, connecting them to their higher goals and purpose. So we talked about external protective factors are that connection, being engaged in work and school, fear of the stigma of suicide, so that prevents people from killing themselves, and these evidence-based treatments. I just talked about CAMS. There's CBT, suicide prevention. There's dialectical behavioral therapy, and there's interpersonal therapy that's been normed for adolescents and for youth. Again, supervision and care I emphasize. So then when we put this all together, we come at people with high risk, moderate risk, and low risk, which should be sort of self-evident to you. Now, as an introduction into safety planning. So we want to, this is another acronym, the SAFE-T, which is talking about how to fold risk assessment into safety planning, identifying the risk factors, protective factors, conducting the suicide inquiry, those 6 questions of the Columbia screen, looking at the risk level, documenting. And always document as if something might happen to you. Where can someone pick up if you're not present to go through the details? Now, here's what we're going to be spending the next 3 weeks talking about, safety planning. We start with those warning signs. And the warning signs are, when do I use the safety plan? If you think of regular healthcare, we want to teach, little kids who are asthmatic, when do you use an inhaler, right? When should you take your sugar if you're a type 1 diabetic? When should you consult a doctor to change your insulin? What says to you, I'm in trouble, right? So again, very idiosyncratic, very specific. Then we move to what they can do for their own benefit, on their own. And only after we go through that in great detail, then we move on to what they can do with a friend. And this is for socialization, for distraction, not for counsel. That's the tell someone coping, not a professional, but it's like, the on my own coping would be for soothing, for distraction, for physiological self-care like exercise, etc. With a friend might be going off for a hike, or seeing a movie or playing a video game together. Anything that's taking me out of the space that's negative for me. Telling someone is, here's the problem that I have. Jen, I'm having some difficulty with a friend of mine. You have a really good way of looking at these things. What do you suggest I do? So that's, you can see that we start with, what are my own resources? What can I do to reach out to friends to make me feel better? And then if I'm stressed out, who do I talk to? Who's safe to talk to? Who's wise to talk to? Who will support my better self that I talk to? Only after all those things don't work for me, then do I go to professional. And again, we don't often do that. What happens is we say, oh, you don't need hospitalization. Here's a hotline to call. Here's a therapist to see. Goodbye. We don't go through any of these, right? Then after the ask for help, which is the professionals, then we talk about reducing lethal means. Why do we do it then, as opposed to at the beginning? Because we've already given people lots of hope. We've given them tools, coping skills, friends that they can identify for support, family members, people who will provide them help and counsel and guidance, and then all our professional resources. And then we say, look at all these ways to support your reasons for living. And now that you feel that way, if there are things that come up that really stress you out, and in that moment you feel desperate, it's really helpful not to have a loaded gun handy, not to have drugs that you could inject into yourself that could kill you, because that moment will pass. It's passed before. So that's why we do lethal means counseling towards the end, not at the beginning. And our last session in this 4-week unit, we're going to spend solely on lethal means counseling. So we can go into that in great detail. So here's the safety plan. Again, the template, warning signs, coping skills on your own, being with a friend, telling a friend, professional advice, lethal means counseling, and then you end up with, what is the most important thing I need to remember about why I should live? Reasons for living. The one thing that is most important to me and worth living for. Reasons for living. and they can be things to look forward to. A lot of people say, I wouldn't suicide because I wouldn't do that to my kids. I wouldn't do that to my friends. Who's going to take care of my pet, right? So it's all the reasons for living, to reconnect to meaning, to reconnect to purpose. And I have a case example for you that when you get the PDF that you can look at. And then in summary, here's how we provide responsible and effective care. Informed consent, we'll go into this in our later sessions. The thorough assessment of suicide risk, which we talked about today. Suicide-specific treatment plans, including safety planning, which is what we'll spend the next 3 weeks going through. Consultation with colleagues, careful documentation, and this is really important, accurate, non-judgmental information, disseminating that to all concerned. And again, we want to end up with life worth living. Developing a meaningful life worth living must be more than just relapse prevention. Coping, problem-solving skills, techniques, enhancing reasons for living, while systematically eliminating existing reasons for dying. And I like to end with Emily Dickinson, hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all. Thanks for being with me. You have my email. Please feel free to email me if you have any questions. And feel free next time we meet to bring up questions in the chat. And I'm going to turn this over to Alex. There's a lot of references, like you can see, about a lot of what I talked about and we'll be talking about in the next couple of weeks. And now Alex is going to tell you how to get your CE code. See you